All right, thanks very much. It's been a great afternoon. I'm really happy to be here. What I'm going to be talking about is, focused on high risk, but I think also, not just for high risk patients, but for all patients. What does the future of myeloma look like? And I'm going to highlight, some data that's going to be presented at the upcoming American Society of Hematology meeting of things that I think look really exciting. And I think what is, in general, what's exciting is that there's a lot, there's a lot of novel compounds and agents that are in the pipeline of many pharmaceutical companies. And I think this is where the future will lead, and it will involve immune therapy, but also new targets. And this is where I think we can see the most benefit for our high-risk patients. So, why is the future bright? I think the future is bright for that reason. There's just so much, CAR T cell therapy, many of you are familiar with. I will talk about that briefly. The most common target for that right now is BCMA. We're seeing the most advanced in development are currently autologous CAR T cells, but we're also seeing, and I'll show some data that will be presented at ASH, data for allogeneic CAR T, bispecific antibodies or T cell engagers. I'm sure many of you have heard about these, and then new targets. And I think this is key. Anytime we're talking about high-risk patients, we're talking about, kind of going off of what Dr. Hari was discussing, high risk is not just the phenotype we see at diagnosis, it's what happens. So if you're, I totally agree. If you have a deletion 17p at diagnosis, but you go on to have a 6-year remission after transplant, that's not high risk. If you have no high risk changes, but you're resistant to proteasome inhibitors, IMiDs, and transplant, that's high risk. And that's where we need new targets like GPRC5D, FCRH5, and I'll show some of that data. CAR T cell therapy. I know this has been kind of in the limelight for the past 3 years. And for those of you who are not so familiar with this, what this basically involves is taking the fighter T cells that our body usually generates to fight off viral infections. And we reprogram them using genetic engineering to target the cancer cells. So this is an amazing therapy, and it really, I think, is a great example of the first example of, or one of the first broadly applicable examples of genetic engineering for treatment of cancer. BCMA is the target that we commonly use for CAR T cell trials. What is BCMA? BCMA is B cell maturation antigen. This is a cell surface protein that is found on the surface of malignant plasma cells and normal plasma cells almost exclusively. And it is just like in other diseases like lymphoma, where we target CD20 or CD19, BCMA is one of the most widely used targets for CAR T cells and also for bispecific antibodies. And now we have an FDA-approved treatment for BCMA, which is belantamab mafodotin. Looking at the data, so this is the most current data that some of this will be presented in more detail at ASH. BB2121 or ide-cel. This is the BCMA CAR that was made by Bluebird and Celgene and now Bristol Myers. And this is the one that hopefully we will see approved for patients in the very near future. From the data that they're showing, overall response rates of 76%, median duration of response 10 months. J&J 4548, this is another BCMA CAR from the CARTITUDE-1 trial. Amazing responses, 94.8% overall response rate. The median progression-free survival, remember that's a measurement that includes roughly, sort of speaking, the time that patients stay in remission, was not reached. They did have 10 deaths on this trial, so something to keep an eye out and look at the data when it gets presented. The JCAR Evolve trial showed a 91% overall response rate. So these are fantastic. And what's great about these responses is that they're seen not just in standard risk patients, but also in high risk patients. We also see toxicities like cytokine release syndrome, which is quite common, although it's uncommon for that to be severe. Cytokine release syndrome is the clinical syndrome we see caused by production of cytokines when T cells proliferate. And this can lead to low blood pressure, fever, or in more severe cases, sepsis and ICU stays. The neurologic syndrome, ICANS, or immune cell associated neurologic syndrome, this is also commonly seen, and this has to do, we think, with potentially cytokine production and T cell trafficking into the CNS. So what's exciting also about these is that these are durable responses. And when oncologists talk about durable responses, they refer to responses that last a while. You know, what's a while? I think, you know, in a patient who is resistant to proteasome inhibitors, IMiDs, CD38 antibodies, you know, the median survival from some prior data is probably around 6 to 8 months. These patients who are getting onto these studies would have probably had that prognosis, and they're now having responses that are lasting 12 to 24 months, and we even have some patients that have had responses last longer than that. So this is very exciting. Why did BCMA CAR T cells stop working, though? And this is something we hope to solve. One thing I like to emphasize when I talk with patients about CAR T cell treatment is that it's early. Think about what transplant was like in the 1970s when it was pioneered, and the you know, the toxicities that we're seeing. We've got it dialed in. You know, we know how to treat CMV. We know how to manage graft versus host disease. But when it started, we didn't have a clue. And so one thing that I think it's important to emphasize is that we're still figuring this out. Why can BCMA CAR T cells stop working? You know, one phenomena that we've seen is that the T cells can become, quote, exhausted. They can take on an exhausted phenotype, which is, you know, the name is exactly what it is. They don't work as well. They don't proliferate. They don't seem to recognize the target antigen as much. We can also see loss or downregulation of target antigen. And I'm going to highlight some data from our center looking at use of a very interesting class of medication called the Gammasecretase inhibitor to improve target density. We've also seen, and this will be shown at ASH this year, patients can actually, we can see selection of clones of myeloma cells that have a deletion of BCMA, which is found on chromosome 16. And then finally, the immunosuppressive bone marrow microenvironment may also play a role. How can we overcome resistance to CAR T cell therapy? Well, kind of, you know, building off of what I just showed, we can increase target density. We can also modulate the immune microenvironment and potentially reverse loss of T cell exhaustion. And there are studies out there that are investigating doing this. What I think is probably most promising is using dual targeting. And this is where, you know, I think, the future lies, is using targets, multiple targets with immune therapy, because we can easily see resistance with using just one target. So to highlight, you know, some of the work we've done with gamma-secretase inhibitors. Gamma-secretase inhibitors have an interesting history. They were actually originally developed as a drug to treat Alzheimer's dementia. They did not have a lot of success there. But then a few years ago, some scientists found that gamma-secretase plays an important role in the biology of plasma cells. It's a protein that's found in the cell membrane of plasma cells and actually cleaves BCMA from the surface. So if you think about it, the last thing you want for a targeted therapy like CAR T cells is to have that target lost. And so using drugs like gamma-secretase inhibitors, we can inhibit this function, potentially increasing the anti-tumor efficacy of CAR T cells. Some of the early data that was generated from this approach is shown here. This is studies that were done in mice, where they combined a BCMA CAR plus Ly. Ly is the gamma-secretase inhibitor. And what we showed, and we can see here in these slides, this is before and after pictures of BCMA expression at the screening and then after GSI. We were able to routinely increase BCMA expression in these examples, and also shown here. This led to the development of a study that we have been conducting here to use a gamma-secretase inhibitor in combination with BCMA CAR T cells. This is the study design here. Patients undergo apheresis. So this is, for those of you who've had a stem cell transplant, this is quite similar to that, except for we're collecting lymphocytes, we're collecting T cells, and then we have to generate the CAR T product, which takes about 2 to 3 weeks. We have to grow the T cells in culture. We have to use a virus to inject the genetic material into the T cells to reprogram them to target the cancer. Once we have done that and the T cells have passed, various tests to ensure purity and quality control, they're infused into the patient after getting lymphodepletion. And the lymphodepletion, the goal of that is to suppress the immune system enough that the T cells are not rejected, because what would happen is if we just gave the T cells without doing that, your body would actually reject those T cells. So we give the CAR T infusion, and then on our study, we give this drug, the gamma-secretase inhibitor, for 3 weeks after receipt of the CAR T cells. We showed that we could routinely increase BCMA expression and surface density. And you can see here, this is a graph showing percentage of BCMA at baseline, and then after GSI, and then also another measurement we called the antibody binding capacity, which is basically a measurement of the surface density of BCMA. And we could routinely increase BCMA percentage and antibody binding capacity on patients on the study. This is a graph here that just shows the responses we can see, and you can see that many patients, many of whom were high risk and were resistant to proteasome inhibitors, IMiDs, and transplant, had excellent responses. We have one patient on study now who's been in remission for over 2 years. So this can work quite well even amongst patients who've been high risk, and also patients who've had treatment with BCMA targeted therapy. So what I would also highlight here is that we were able to show a 100% overall response rate, even at the lowest dose level. This is a dose level that's been investigated by other BCMA CAR T cell studies and is not quite effective. But I think, using a gamma-secretase inhibitor and increasing the target density, we really can improve responses even at low dose levels. Other avenues for improving on CAR T cells. So a lot of the data that we've seen in national meetings and talked about in the media has been with autologous T cells, which means T cells that come from you. Allogeneic CAR T cells are a very intriguing avenue towards overcoming some limitations that we see with autologous CAR T cells. So basically these would be T cells that come from healthy donors. So one potential advantage is the T cells that we're getting from those donors are more robust, less likely to have issues with exhaustion. And another advantage is manufacturing. If you think about it, if you have T cells that are already collected from a healthy donor, you don't need to wait to create the CAR T cells. You can just give them when they're ready. And that's something people sometimes refer to as off the shelf. Concerns, GVHD. And so just like with allogeneic transplants, there is concern for GVHD, where if we give these T cells, even though they've been genetically modified, they could still provoke an immune response against the person receiving them. And another big concern is alloimmunization, which is rejection of these T cells by your body. There are currently several. I lost my microphone. Did everyone catch that? So the CS1 SLAMF7 targeted allogeneic CAR T cell is one such study. These are allogeneic engineered T cells. They use a genetic engineering modality called TALEN for gene editing, and they inactivate the T cell receptor alpha constant to reduce the risk of GVHD in patients who get this. And this is currently in a phase 1 study. I think actually at last I heard this study was on hold, but I just really want to highlight this as an example of one such allogeneic CAR T. Another one that I think is really exciting, and the full data for this will be presented at ASH, is ALLO-715, and this is a anti-BCMA allo CAR in relapse refractory multiple myeloma. In the interest of time, I'm not going to delve too much into the data, and I think we'll be very excited to see this presentation at ASH. But they saw an overall response rate of 60% at the dose level 3, and no neurologic toxicity or GVHD was reported. So this is very exciting. What are some other non-BCMA targets for immunotherapy, and not just for immunotherapy, I guess, but also you could say for antibody drug conjugates or for bispecific antibodies, because one of the issues is that over time we would expect to see resistance through some of the mechanisms that I've mentioned. So I also highlight this because I think it's important to note that one of the major issues with high risk is resistance to many of our standard therapies. And so it will be really, really critical to have multiple targeted agents, potentially ones we could use together or sequentially to really try to get to MRD negativity, which is so important for high risk. So the ones I would highlight today are GPRC5D and FCRH5, both of which are new targets for myeloma. GPRC5D is G protein coupled receptor class C group 5. I know that's quite a mouthful. And what this is this is a cell surface protein that's highly expressed on malignant bone marrow plasma cells, but normal tissue expression is really limited to the hair follicle. And what this shows here, this is a graph that shows mRNA expression in various cancers, and you can see here it's very clear that in myeloma we see very high expression levels. This led to not only a study using GPRC5D targeted CAR T cells, but at ASH this year we'll see data from the first study of a bispecific antibody. And just a refresher on bispecific antibodies, what do these drugs do? These are molecules that one arm of the molecule attaches to a protein, a marker, in this case GPRC5D. Others have used BCMA on the surface of plasma cells. The other arm attaches to or binds to CD3, which is a marker on T cells. And what this does is this is kind of similar conceptually to CAR T cells, because this molecule tells the T cells to target the cancer. And those cancer cells then undergo apoptosis, which means cell death. And so this is the first study of a bispecific antibody targeting this new target GPRC5D, and they see very promising results with an overall response rate of 78% and 4 patients who have an ongoing response at 15 months. As we would expect, we see side effects like cytokine release syndrome and neurologic toxicity, which, just like CAR T cells, we do see that with bispecific antibodies. Another exciting target is FCRH5. This is also found uniquely on malignant plasma cells. And so this is a study that will also be presented at ASH this year in a couple of weeks of a T cell engager that targets FCRH5. And we also see impressive overall response rates, including responses in high-risk cytogenetics, but also common CRS and cytopenias. So to conclude, and I know I'm running over a little bit here, I just want to highlight where I think things could be going. What does the future look like? And so, as an example of this, there was a very, I think, exciting study that was published recently in New England Journal of Medicine, looking at this paradigm of using targeted treatment plus immunotherapy. And this example is actually in Philadelphia chromosome positive ALL, acute lymphoblastic leukemia. In this study, patients got targeted therapy. Dasatinib is a tyrosine kinase inhibitor that is used in Philadelphia positive ALL. After that treatment, they got blinatumomab. Blinatumomab is an FDA-approved CD19 bispecific antibody for 2 cycles plus targeted therapy with dasatinib. And the primary endpoint of the study was the molecular response after 2 cycles of blinatumomab, and they showed amazing results. This is a Kaplan-Meier curve. Remember, we've looked at these in prior presentations, and you can see that the overall survival for this, an aggressive acute leukemia is quite impressive. So I think this paradigm of using targeted therapy plus immunotherapy is one we can easily, utilize in multiple myeloma. So, and this is just sheer conjecture. I mean, who knows what the future holds, but what could we see? So this is the present, PI, proteasome inhibitor, IMiD, CD38 monoclonal for induction, autologous stem cell transplant, perhaps a tandem for high-risk patients, and then maintenance with our IMiDs and PIs. But what could the future look like? Maybe induction will still be the same, but maybe consolidation, we will have dual targeting immunotherapy, maybe an allo CAR or T-cell engager, or maybe BCMA plus a GSI. And then maintenance, maybe we'll be using an IMiD plus bispecific antibody. And again, I'm not necessarily saying this is what I would, recommend, but I think these approaches have a lot of promise towards transforming the care for high-risk patients and all patients with multiple myeloma. So in summary, many advances are being made, and I hope I've left you with that impression. And really what I want to leave you with today is the future looks bright. There are a lot of new drugs, there are a lot of new targets, and so far the results, the efficacy, the responses, and the durability of the responses are quite good. I think that CAR T, bispecific antibodies, and ADCs like belantamab and other ones that will come all have immense promise to transform the care of relapsed multiple myeloma. And I think we'll see this move into newly diagnosed over time as well. And I think, again, the future is bright. Think about how far we've come in 20 years, where 20, 30 years ago, it was thalidomide and melphalan, or even interferon. And now we have lots of options and lots of things that are, lots of drugs and compounds that are moving through the pipeline and coming to patients. So with that, I will conclude, and thank you.
Thank you, Dr. Cowan. That was a great overview, really great. And I also want to focus on the fact that the CSI CAR T is something that's developed at the Hutch, correct?
That's correct. The GSI came out of Damian Green's lab and Stan Riddell's lab, and that turned into a clinical trial. So that's a great example of, this kind of, I guess, perhaps cliched term, we say bench to bedside, but this is exactly that. This is emblematic of that.
Mm-hmm. Well, I think it's interesting because you have commercial CAR Ts that are being developed, and you have these, in-house, and you have these allogeneic or donor off-the-shelf approaches. So I just think it's going to get better from here.